Robert Spetzler. I'm still president and chairman emeritus at the Barrow Neurological Institute and professor of neurosurgery at the University of Arizona. You're listening to Interview with the Surgeon Agent.
On this episode of Interview with the Surgeon, we welcome Dr. Robert Spetzler, a world-renowned neurosurgeon who specializes in cerebral vascular disease and skull-base tumors. He has been involved in pioneering the technique of hyperthermia, cardiac arrest for the treatment of difficult brain lesions. He has been honored many times by professional societies, including the American College of Surgeons and the Congress of Neurological Surgeons. In 1994, Dr. Spetzler was chosen to be the honored guest of the Congress of Neurological Surgeons. At age 49, he was the youngest recipient of this prestigious honor. He served as president and CEO of Barrow from 1986 to 2017. Dr. Spetzler has published more than 300 articles and 180 book chapters in the neuroscience literature. He has co-edited a number of neurosurgical textbooks, including the Color Atlas of Microneurosurgery.
Hello, everyone, and thank you for joining Interview with the Surgeon. Today, we welcome Dr. Robert Spetzler, arguably the most well-known neurosurgeon on planet Earth. Doc, how are we doing today?
I'm fair and looking forward to this interview.
Great. Well, let's just jump right into it. What were your goals and aspirations during your residency?
Well, you know, the neat thing is that I knew I wanted to be a neurosurgeon even before I entered high school. My yearbook, first year, where it says, what do you want to become? It was neurosurgeon. So it gave me a focus for this specialty, so that in high school, I already sort of concentrated on areas that might have an impact on neurosurgery. In college, I worked in a research laboratory, state research laboratory, where we did studies on blood flow in dogs. And when I went to medical school, I went to a medical school specifically because the leading neurosurgeon at the time, Dr. Paul Busey, was at Northwestern, and I spent time in his laboratory. So I had a unique perspective on neurosurgery, and that I was focused on it from a very young age. During residency, my goal was really to learn the craft and to publish and do research, because there was never any doubt in my mind that academics was my future. I was fortunate enough to train with somebody named Charlie Wilson at UCSF, who was a young rising star. And that gave me the opportunity to be very productive during my residency. During my residency, I was able to talk Charlie Wilson into letting me go to Europe for a 6 months sojourn, where I visited some of the most famous neurosurgical European centers. That included Switzerland and Vienna.
What was your mentality getting into your first job search, and how did that perspective change in the beginning years of your career?
Yeah. When I was in my chief year in San Francisco, I had a number of offers for jobs that included one to stay at UCSF. Problem with that was that it's very hard to be a philosopher in your own land, and my boss, or a prophet in my own land. My chief would always be there, no matter how successful I was. It'd still be arm around the shoulders. Yeah, you could have done this or that. Then I had a job at Yale, and for those that are still interested, the average salary at that time in academics was probably at $80,000 to $100,000. Private practice, maybe 2.5 times that far. But at Yale, the offer they made me was $35,000. That was barely more than I made as a chief resident. I ended up going to Case Western Reserve in Cleveland. And the reason I did that is because when I started the residency, microneurosurgery, that is operating through a microscope, an operating microscope, was really the leap that propelled neurosurgery forward. So I was an expert in that. And at Case Western, there was nobody that was a microneurosurgeon. So it allowed me to be really somebody that provided a new skill level in a program that then attracted residents and fellows that wouldn't have happened if I hadn't come with that skill level to Case Western.
What would you say were some of the keys of your success that shaped your early career as you climbed the top of your industry?
Yeah. I can tell you that probably one of my biggest successes was that I could enthuse the residents around me. They bought into my vision, that is to work very hard, at the same time to spend time with your family and play hard. And when you have residents that buy into this track, then they are incredible motivators. That means you've got to come up with research projects for them, to find a spot for them in your laboratory, and to encourage them to write papers and publish. Neurosurgery, in order to really do it well, has to be full of passion. It really can't be a 8-hour day job. That's just not how it works. So if it's a passion and you enjoy it, then being woken up at 2 o'clock in the morning is not a chore. It's part of your profession.
Now, with a historic storied career, what were some of the key highlights that you would say that really helped shape the industry?
When I started my residency, there was a incredible explosion of neuroimaging. That means looking inside the brain. When I started my residency, they were still doing things called pneumoencephalogram, which is a barbaric way to try to find abnormal shifts inside the brain. And that was accomplished by putting a needle into your back, into the spinal fluid, sucking out some spinal fluid and putting air in. That air would then rise up the spine, along the spinal cord, and up into the spaces where that fluid surrounded the brain, and inside the brain, things called ventricles. Then you took regular x-rays, and because you could see air on those x-rays, you could see whether those ventricles and that space where the air displaced the spinal fluid was in its normal anatomical position. In order to get that air into all sorts of different locations, that patient was strapped into a chair, and that chair was able to rotate 360 degrees, so they'd be upside down. Many of these patients would end up vomiting terribly because of this. And that was the stage of trying to find abnormal shifts from the normal anatomy. And that was a lot of subtlety involved and a lot of misinterpretation, misdiagnosis. Then came along computerized tomography. And computerized tomography basically is thin X-ray cuts, and you have differentiations in the different portions of the brain. So it provided for the first time a look inside the brain without making a patient incredibly ill, like with the pneumoencephalogram. And then not very long after came this incredible diagnostic tool called the magnetic resonance imaging. And an MRI scan not only had incredible resolution of the brain, but could also be used for other things like functional imaging. Functional imaging is where you ask the patient either to do to think about something or to move an arm, and whatever portion of the brain that controlled, that would light up because it would require more blood flow. And that differentiation you could see on an MRI scan, so you could actually now look at function of the brain. So these are by without a doubt the greatest advances in neurosurgery in my lifetime.
What would you say were some of the most memorable moments during your time at Barrow?
God, there were a lot of them. We became the center for the most difficult vascular cases in the world. So patients would come from around the world. And we did a lot of what are called cardiac standstill patients. That is basically where you take a patient, you make them hypothermic. At a certain temperature, your heart fails. So it would be put on a heart-lung machine pump that would then take over the function of the heart and the lung, and you would bring that temperature down more and more until you were down to maybe 15, 14 degrees centigrade. Then you'd turn off the pump, take a lot of blood out of the body, and then you'd be able to operate in a field where there was no respiration, there was no blood pressure, so that if you had something like an aneurysm, which is a balloon and a blood vessel in a most difficult portion of the brain, that could collapse. And so you had up to an hour where you could manipulate that sac, bring it together, and just like at the bottom of a balloon, put a clip on the origin of that and save a life that otherwise we would have had no solution to. So that was probably one of the most dramatic events, and we published, I think, 106 or 103 cases, by far the most that had ever been done that way. Another thing is arteriovenous malformation, which are tangles of blood vessels. We developed a grading system that's used around the world, differentiating the most difficult arteriovenous malformation and those that are relatively simple, so that you could compare between series when they were categorized in that way. So those are two good examples.
Being someone that has trained more neurosurgeons than anyone else in the world, what are some of the biggest mistakes you see young surgeons making?
Well, I prefer that we ask what were the things that made them really successful. But yes, if I would say the biggest failure that I dislike the most in a person is when they kick down and kiss up. Now, because I've been on the top so long, that last portion about kissing up is not so bad anymore. But kicking down, and that comes down to this fact that we've never taken a resident applicant if we got feedback from a nurse or from a secretary that they did not behave in an appropriate manner. Because if you don't respect the people that make everything possible, the technician, the nurses, all the infrastructure that allow us to do our craft, then you're not worthy of being a neurosurgeon. Not caring is probably the worst, because if you don't care about how your patient does, then you can't learn from mistakes. There is no doubt that in neurosurgery, you have your highs and you have your lows. You have devastating complications. And it is absolutely necessary that when something bad happens, and if you're a neurosurgeon, something will, you go back, you analyze it over and over again, and see if there's something that can be changed to avoid that from happening the next time. In order to really create camaraderie among the residents, which I thought was a very, very important aspect of the training, we did a lot of activities that included the resident and their families. So, for example, we had a hike going across the Grand Canyon every year, the annual Rim to Rim hike. And we'd have neurosurgeons, colleagues come from around the world, the residents, their families that could make it. And I can't tell you how many of them, nurse would come up afterwards and say, this was life-changing for me, because it's a 23-mile hike with 1 mile change in elevation. It's a big thing. Then we had a hike that went 14 miles down a riverbed where we had to do some swimming, no trail. Then we had Olympics where we would compete with every physical sport with UCLA for many years, and then others. We would have parties which always included the families. And we would have weekend volleyball games at my house. the residents and attendings who were there, and biking with the fellows and residents. So I wanted to create a family environment where the families themselves got close enough to other families that were going through the same process, because whoever, whether it was a he or a she, the resident spent so many hours away from home. They needed to connect with others that went through that same sort of process.
What advice do you have for the graduating resident fellows entering the professional job market for the first time?
Probably the most important lesson, and I've said that over and over again, is you're starting out, you think you know everything, you don't. The last thing you want to do is bite off more than you can chew. This maturity of doing difficult cases comes with time. It's not what you want to start off. Because once you have a reputation as a wild person, that is hard to overcome. But if you just do what you know very well and you have success, then your colleagues around you that refer you patients will think highly of you. If you take on something that you're very likely to have a big complication on, you have a lot of road to overcome.
Seeing that there's a human element to being a surgeon, what advice would you have given your younger self with all the experience you have now when complications do happen in the OR and you don't have an ideal outcome?
Yeah, I've lost many a night's sleep because of complications. And I think I mentioned before, I think what is really critical is that you care deeply. A complication is unavoidable. Learning from it is what is truly essential. I think the other part of that equation really is being fortunate enough to find somebody to share your life with that acquiesces to all sorts of breaks in social expectations, spending New Year's Eve in the hospital in an operating room, and understanding that as a neurosurgeon, the word no is really not in your vocabulary. When somebody needs you, when somebody calls you, you go. Fortunately, I married a neuroscience nurse that was a neuro-oncology nurse. And so she was fully understanding, and there wasn't a single time that she flagellated me for not making something. So that's a blessing. As I said, I knew I wanted to be a neurosurgeon very, very early in life. But I was born in Germany, and when I was 5 years old, I stepped on a little rusty nail, and I contracted a disease called tetanus. And I remember our family physician being puzzled by this strange illness this 5-year-old had. And so he sent me to a neurologist. My parents took me there, and he diagnosed tetanus and said, you need to go to the university hospital. That was planned for the next day. That's where I was going to go. In the middle of the night, my parents had put me in just outside of their bedroom so that they could hear me. I had one of these tetany attacks and broke a vase that was very, very special to my mother. And when they came charging out of the bedroom, I expected reprimand and punishment, and instead she hugged me to her bosom. And in the middle of the night, we drove to the university hospital. My dad telling me story after story to keep me awake, because every time I drifted off to sleep, I would have these tetany attacks. Got to the emergency room where my memory, like 12 white coats, held me down on the table while one cauterized the little wound I had. I was so far gone that they didn't want to put me in the pediatric ward, and instead they put me into the iron lung storage room. And so these big iron lungs that kept polio victims alive when they couldn't spontaneously breathe. And I remember my mom's face against the little oval window in the for that storage room. And she wanted to take me home because if I was going to die, I wanted to die at home. But they had a new drug from America called penicillin, which I received. And obviously spent multiple months in the hospital. And I remember very distinctly being carted to an auditorium that to my 5-year-old eyes, it just seemed immense, full of white coats. And the physician that saved my life put me on a little table in front of the audience and then took off my hospital gown to do the reflexes. And I remember to this day, the incredible embarrassment I felt standing on that little table as a 5-year-old, completely unclothed. And I've always thought that that was sort of a lesson that I hoped helped me be a little more sensitive to our patients, because we see these terrible things day in and day out, become sort of immune to them. For them, naturally, it's a life-changing experience. But nobody in my family had gone into medicine. They were scholars, academicians. And so I am sure that this experience is what led me into medicine.
We hope you enjoyed this episode of Interview with the Surgeon. Until next time, stay focused and keep following your dreams.